such a beautiful, loving, warm introduction. And, you know, I have to say, I feel the same way. This has really been the light during such a difficult time. You know, what started off as a couple of webinars just to get our minds going and stay in contact turned into this powerful dentistry academy that created this incredible network of dentists and colleagues, and really creating a network for dentists and recent graduates who just unfortunately may have just finished a little sooner than they had to due to COVID. And I feel so grateful to be part of this lineup of lectures that we've had over the course of the last couple of months. I think this is actually my third webinar with you guys. Through this, you know, I've been able to reconnect with colleagues that I haven't seen in like 15 years. And I've also been able to create friends that I know will last a lifetime. I just hope to meet them in person, see them in person again one day. So anyways, thank you so much for being here on a Wednesday at 6 p.m. on such a beautiful day. So I am a periodontist. I've been practicing for 14 years here in Toronto and now London for the past couple of years. And I really wanted to talk about this new periodontal classification because there's so much mystery around it. And, you know, it's not so new. I mean, it's been around. It was published in 2018, and yet we're still calling it a new classification. And after using it for quite some time, it's really not that bad. In fact, I'm actually very fond of this classification. So I thought, what better time now that we do have some time and we're just a couple of steps away from opening and going back, that we set our feet on the right path so that when we do go back, we can give our patients the best care possible. So let me just see here. So again, Dr. Shergin's done such a great job in terms of introducing me. I don't think there's even very much that I can say here. I have to say this lecture is quite interesting for me because I have done a lot of lecturing on flap design, suturing, bone grafting, mentorship, and implant placement. And yet the periodontal lectures are, you know, far and few between, which is really unfortunate because my true love truly is epidemiology and periodontal disease and really understanding that. And truthfully, you know, periodontal disease also affects long-term implant health. So I think that this all comes together. I am, again, very proud to be part of Dentistry Academy, and I've also created Global Dental Academy, which is really at its infancy. Global Dental Academy is very true and dear to me. It is a platform for me to be able to discuss periodontal disease, implants, anything that really is relevant in dentistry. And I have a few ways of contacting. Dentistry Academy, which is very dear to my heart, is here. You can reach them on Instagram and their website. And I'm just at the infancy of creating Global Dental Academy. You can find me on Instagram through Dr. Tina Kokosis and my just new Instagram page, Global Dental Academy. You can also reach out to me at the website gda_education@yahoo.com. I also want you guys to know that I have accreditation and I will be providing 2 CE credits. They're going to be, for our CDO, they're going to be Core 2 credits. So what's going to happen is at the end of this lecture, I am going to provide a verification code. And what I want you guys to do, and you can do it in the chat box as well, is in the chat box, write the verification number. We'll leave it up for a few minutes after this lecture's over. Write the verification number plus your name plus your email address, and I will send you a certificate over the course of the week for the CE credits. In terms of the lecture outline, again, my true love is treating patients and giving back to the community. And I find that the longer I'm a periodontist, the more I love going back to my roots. So I really love to share this classification so we can all learn from it together and communicate together. And don't feel bad if when you heard that there was a new classification out there, the first thing that you guys may have said, and you probably aren't the only ones, that, oh my gosh, not a new classification. Periodontal disease is confusing enough as it is. A lot of people don't understand periodontal disease already. The classification that we were using was from 1999, so it has been around for 20 years. And suddenly here we are having to face a new classification. And so I am here to let you know it's easy, it's manageable, it's doable, and I'm here to show you how. Okay, so this webinar really is a definite introduction. And if anybody knows me and has heard me speak, I'm quite detailed in my webinars. So I guarantee you're going to walk away with a lot of pearls and understanding how to use the new periodontal classification. But there is still so much more information that I will not be able to cover today. And what I really encourage you guys to do is go to Perio.org, which is the American Academy of Periodontology website. And you go to member resources, and for free, if you scroll down that tab, you'll go to the proceedings of the 2017 World Workshop, where there's a lot of information there that will help you. This is, I'm going to highlight the key parts of this classification. And if you guys are interested, I mean, I'm more than happy to keep going and even provide other webinars to discuss the rest of the classification with you guys. So how did this classification come around? So in 2017, the American Academy of Periodontology and the European Federation of Periodontology sponsored the World Workshop to develop a new classification of periodontal disease. And the reason for the new classification is to align with emerging evidence, the latest evidence that is relevant to periodontal disease since 1999. Also, it created, and what they wanted to do was create an international communication tool, a standardized tool where we as colleagues and we communicate with our patients are able to have a dialogue that's standardized with our patients. And in doing so, we are able to create a patient-specific treatment plan for our patients. So basically what we want to do is just align with the evidence that's present to us today. And so let's compare the classification. So here we have the 1999 classification. And if you can see here, first and foremost in the 1999 classification, there was gingival diseases, which was biofilm or plaque-induced and non-plaque-induced. That remains the same. But in addition to that, the 2017 classification now defines periodontal health and gingival health, which makes complete sense because if we want to understand disease, we also need to understand health. So we now have a new definition of what periodontal health and gingival health really means. Second of all, the 1999 classification had chronic periodontitis and aggressive periodontitis as two separate diseases. So chronic periodontitis in 1999 was classified as slight, moderate, and severe. And it could be localized or generalized depending on whether there were less than 30 sites involved or more than 30 sites involved. And then we also had aggressive periodontitis. Aggressive periodontitis by nature, just by saying the word aggressive, means it's severe. So there was no mild, moderate, severe with aggressive periodontitis, but it could be categorized as localized and generalized. And in 1999, these were thought to be different diseases because they expressed themselves differently in the mouth. So chronic periodontitis was more a period of breakdown, periodontal breakdown and repair. It wasn't linear, but it was more of a slower progression, where aggressive periodontitis was more of a rapid progression at an earlier onset for anybody who's been practicing and been in the industry for a long time, such as myself, I remember the classification before 1999 that had aggressive periodontitis as localized or as juvenile periodontitis, which was a prepubertal expression of periodontitis. So at a very early age. And it could be localized or generalized. And localized means it had a molar incisor pattern, which means the breakdown occurred mainly around the molars and the incisors. But what's different with this new periodontal classification is the World Workshop, after looking at all the research, realized that although aggressive and chronic periodontitis express themselves differently clinically, pathophysiologically, they're actually the same disease. So instead of grouping that, or instead of separating them again as chronic and aggressive periodontitis, they're actually just known now as periodontitis. And that is the most, that's the newest, most, I guess, the most relevant part of that new classification that really relates to us on an everyday basis. Then, of course, very similar, we have periodontitis as a manifestation of systemic disease, necrotizing periodontal diseases, abscesses of the periodontium, periodontitis associated with endodontic lesions, and developmental or acquired deformities and conditions. Those relatively stay the same. But another new highlight in the new classification is finally a definition of peri-implant disease and conditions. Since 1999, implants are mainstream. Implants are part of our everyday life. We will see implants all the time, and we need to know how to define that in a standardized way. So let's take a look at this. Ultimately, this is what our classification now looks like. And if you actually go onto that perio.org website, these blue links, if you actually link onto them, it will take you to the consensus reports that were developed with the workshop. I'm going to focus mainly on periodontitis today. I am going to talk a little bit about gingival health, because again, in order for us to know disease, we have to understand health. And we're going to touch upon peri-implant diseases and conditions. So this is what happens. We are going to have patients walking into our clinic that are going to range from health to disease. And in order for us to be able to provide the best care we can as dentists, as dental hygienists, as a dental team, we need to look at periodontal disease as a patient-specific disease. And when looking at periodontitis as a patient-specific disease, what we're also going to do is create a personalized risk assessment for our patients to predict future disease before it's even expressed. And in doing so, we will be able to create the proper care for our patients. And that, my friends, is the essence of the new periodontal classification. And I'd like to say we can stop here and end the session, but I have a lot more to say. But ultimately, I want to repeat that again. We need to review periodontal patients and periodontitis as a patient-specific disease. And in doing so, we create a personalized risk assessment for our patients. And we want to try to develop predict the future before we even express further periodontal disease. And in doing so, we will create proper individualized care for our patients. And that is known as precision medicine in dentistry. Okay, very important. That truly, as I said before, is the essence of our new classification. And before we even talk about the classification, I want us all to be on board. Let's talk about what periodontal disease is. Well, periodontal disease is multifactorial. And this is where it gets confusing. A plus B does not equal C. So what that means is we will have people who will express disease very differently in our office. First and foremost, what we know is we need biofilm. We need plaque, okay? Plaque occurs in an organized manner, okay? In doing so, when we do end up having plaque accumulation around our tooth, we will develop gingivitis, okay? Everyone does develop gingivitis. But gingivitis but not everybody goes from gingivitis to periodontal disease. Okay, so it's not linear. And what happens is everybody has a different activated host response to the biofilm. So what ends up happening here is I compare it to a peanut allergy. Why is it that some people will develop a peanut allergy and others can eat peanuts all the time without any allergic response? Why is it that some people can eat burgers every single day? Some people will develop cholesterol even or as an early onset, as an early adult, and some people will not have cardiac issues. I hate to bring up the dreaded COVID, but I will. Why is it that some people barely express COVID signs and symptoms and other people have an exaggerated response? It's because we all have a different activated host response. Some people will come to your office and have a lower threshold to the biofilm, okay? Now, to also, to also add on to this are co-determining factors, primarily diabetes and smoking. And what we know is diabetes that's uncontrolled, and I'll define uncontrolled diabetes soon, and smoking, especially patients that smoke 10 cigarettes a day, will actually have more destructive periodontal disease. And they will also express periodontal disease at an early age. But not only that, patients who have these co-determining factors also do not respond that well to therapy, okay, and they will have greater tooth loss. So really, periodontal disease is multifactorial, okay? So again, in order to understand periodontal disease, we need to understand periodontal health. So periodontal health, according to the 2017 workshop, periodontal health is defined as no clinical attachment loss. That makes sense. No radiographic bone loss, makes sense. And bleeding on probing of less than or equal to 10% of sites. So you would think that periodontal health would mean zero bleeding, but that's not necessarily the case because it's very difficult for us to find patients who have 0% bleeding scores, okay? And also, when we do probe, we're not exactly consistent with our probing. There's different operation heavy-handedness maybe that comes with some of the probing. We're supposed to probe at 0.25 newtons or 25 grams, but let's face it, what does that even really mean? So periodontal health is defined as having less than 10% bleeding sites. Gingivitis, okay, is when we have no clinical attachment loss, we have no radiographic bone loss, but we have bleeding on probing of greater or equal to 10%. Okay, and periodontal disease is classified as clinical attachment loss on at least 2 non-adjacent teeth. And when we say 2 non-adjacent teeth, that means that if we had clinical attachment loss on 1/6 distal and 1/7 mesial, okay, those are 2 teeth, but in essence, we consider that the same area. Okay, so it has to be 2 non-adjacent teeth. And I just want to point out here, when we talk about clinical attachment loss, we're defining clinical attachment loss with periodontal disease around interproximal regions. So interproximal clinical attachment loss. Reason being is because there are a lot of reasons why we will have attachment loss, for example, on the buccal or the lingual of teeth that are not periodontally related. For example, recession from trauma. Maybe a crown lengthening was performed. There may have been caries, or even the removal of wisdom teeth. Impacted wisdom teeth will create a bony defect on the distal of the 7s. And that really wasn't caused from periodontal disease. And that is why we actually define it as interproximal clinical attachment loss. And also, if we are going to look at the buccal or lingual surfaces and define that clinical attachment loss as a periodontal disease manifestation, they define the workshop defines it as clinical attachment loss of at least 3 millimeters, okay, with pocketing of 3 millimeters. Okay, so there has to be, for example, recession, and then there should be at least a 3 millimeter pocket in that area to determine that that was a manifestation of periodontal destruction on the buccal or on the lingual. And this is really, I think this is the coolest photo. And just like I said, so we can be on the same page as I'm explaining periodontal disease and the new classification. If you take a look here, this is the tooth. We have the enamel here, we have the root surface here, and we have the CEJ. Our tooth is lined with soft tissue. We have the gingival sulcus. At the base of the gingival sulcus, to where the CEJ is, we have a junctional epithelium. And that is attached to the tooth with a hemidesmosomal attachment. And then right at the juncture of the CEJ, we have the connective tissue attachment. Okay, and I'm just going to take you right here to this little picture here. If you take a look, this is the junctional epithelium that's attached to the tooth. And as we get to the CEJ, we actually only get, we have one terminal cell of the junctional epithelium right at the base where the CEJ is. So we call that the terminal cell of the junctional epithelium. And once that's actually breached, that one terminal cell of the junctional epithelium, once that's breached, okay, that is, and we start getting a clinical attachment loss of that connective tissue at the base, apical to that junctional epithelium, that's when we start developing periodontal disease. That is the point of periodontal disease or clinical attachment loss. So let's go ahead and further look at the definition of periodontitis. So how do we define a periodontal patient clinically? First and foremost, in order to identify a periodontal patient, we need a full set of x-rays. And I would highly encourage periapicals and bite wings. I know that we're taking a lot of panorexes now, but it's very hard to determine and to identify bone loss and bone patterns with a panorex. So I really love having a full set of x-rays, whether they're periapicals and bite wings. We also need full records, including a periodontal charting. And periodontal charting should include probing, bleeding, attachment levels, recession depth, furcations. We should also have a thorough medical assessment of the patient, identify any of those co-determining factors such as smoking and diabetes. And we should also have a dental assessment with the patient as well, including loss of teeth. Have a history of why these patients actually did lose the teeth, or the teeth lost because of periodontal disease. And I'll explain why that's so important soon. Or was it lost due to trauma, due to caries, an unfortunate accident? Then what we have to do is define the type of periodontal disease. Is it periodontitis as a manifestation of systemic disease? Is it necrotizing periodontitis, or is it that new definition, periodontitis? And then if we define the periodontal patient as having periodontitis, what we have to do, as I said just a few minutes ago, is we need to develop a patient-specific disease and create a personalized risk assessment. And the way we do that is by staging and grading our periodontal patient. So let's take a look at the previous 1999 classification one more time. When we looked at the periodontal classification in 1999, periodontal disease was classified by extent, and it was classified as severity. But there were so many pieces of the puzzle that were missing. There were so many things that just weren't fitting together. We weren't predicting the future quite yet. So let's take another look here. Looking at the 1999 classification, this is what our diagnosis used to look like. Localized mild chronic periodontitis. Or maybe we had a patient that had generalized severe chronic periodontitis. Or perhaps we had a patient that had generalized moderate chronic periodontitis with localized severe chronic periodontitis. Okay, and then we also had localized aggressive periodontitis. So what we did was the localized determined the extent, okay, so the number of teeth, less than 30% or greater than 30% of the teeth or the sites affected. Then we talked about the severity. Was it mild, moderate, or was it severe? And then we had our diagnosis, for example, aggressive or chronic periodontitis. But here's the thing. This definition of periodontal disease is one-dimensional. What I mean by that, and what the workshop means by that, is the definition or the diagnosis of periodontal disease only defined periodontal disease as past destruction. It told us nothing about future destruction. So this was what we call, or what they called, I like to say I was part of the workshop, but I was not, what they called these, the 1999 classification was a one-dimensional diagnosis. So what we do now, and what the classification has changed, is we still have extent and severity, but we also now include the rate of progression of periodontal disease. We want to assess the rate of progression. We want to define the complexity of the management. So we want to take into consideration probing depths, horizontal or vertical bone loss, furcations, tooth mobility, missing teeth. These are local factors that will also tell us more about the progression of this individual periodontal disease. Because again, this is a patient-specific disease now that we want to classify. And we want to determine if there are any risk factors. And I just want to start off by saying too that periodontitis is the definition, but that's not a patient-specific, that's not defining the patient in a patient-specific way. So what we do is we take that periodontitis and now start to define it further so we can better determine the progression of periodontal disease on a patient. And the classification took oncology, the way we looked and defined tumors, and used that as the classification for periodontal disease, or in further defining periodontal disease, because the diagnosis is periodontitis, but we want to further define what periodontitis means for that patient, okay? So in oncology, to define tumors, severity or stage looked at the clinical representation of the disease at the time of assessment. And then we had grading. We have grading of the tumor, which predicts or tells us the risk of progression of that tumor. So what the classification did, the workshop did, was take periodontitis as a diagnosis and said, let's personalize this diagnosis. And so what we do is we further define the definition or the diagnosis of periodontitis. And now we look at staging and grading a patient. And staging will look at the severity of the clinical presentation of the disease. It looks at complexity and the extent and distribution. And grading looks at the rate of progression. We consider modifiers. And again, we want to see if there's any risk of further progression. And again, these help us define the diagnosis of periodontitis for that patient. So if you go to perio.org, which I mentioned earlier on, earlier on in the website, or just email me and I will give you guys these charts. They were created by the World Workshop, and what they do they are clinical tools that help us to further define staging and grading for our periodontitis patient. And it looks really scary. Quite honestly, when I saw these charts initially, I was a little intimidated by it. And this is also, I think, why a lot of us are not using that classification as often as we should, because we don't quite understand the staging and grading. So let's look at this together. When we look at staging a patient, there are 4 stages. There's stage 1, which is what used to be known as mild periodontitis. We have stage 2, which used to be known as moderate periodontitis. And then we have stage 3 and stage 4, which are similar until we get down to the bottom, and this is severe periodontitis. And in order to define what stage we want, we look at first the interdental clinical attachment loss. And the beautiful thing is we don't have to look at every tooth that has clinical attachment loss to determine if it's stage 1, stage 2, stage 3, stage 4. We take a look at our patient, we take a look at the charting, and we look at what site has the greatest clinical attachment loss. And that is how we define this part of the staging. So if a patient has 3 to 4 millimeters of clinical attachment loss on the worst affected tooth in the dentition, it would be considered stage 2. And I will tell you that stage 1, in my opinion, is probably the hardest to define, because 1 to 2 millimeters of clinical attachment loss is not a lot. And a lot of times, just by our probing, sometimes we're not 100% accurate with our probing. Sometimes we probe a little harder than we should. Sometimes there's calculus in the way. We may not probe as deeply as we should. I actually find stage 2, stage 3, stage 4 the easiest to actually classify. So don't be scared, or don't feel confused, or don't give up too soon if you find that you're having a hard time actually trying to figure out a stage 1. The next thing we do to determine the staging is we look at radiographic bone levels. And back in the 1999 classification, we really didn't look at bone loss that much in terms of looking at periodontitis, but we do in this case. And if bone loss does not exceed more than 15%, if we don't get bone loss on up to 15% of the root, that's considered stage 1. Stage 2 is when we have radiographic bone loss from 15 to 33% of the root. Stage 3 is when we have bone loss that extends from the middle of the tooth and beyond, okay, the root of the tooth. Now, tooth loss also is very important for us to determine the staging. And if a patient has no tooth loss, we circle otherwise stage 1 or stage 2. And by the way, guys, I have examples coming where we're going to look at a few cases together. Stage 3, and the way you define stage 3 or stage 4, because up to this point they're quite similar, is if a patient has less than 4 or less teeth that have come out as due to periodontal disease, it is stage 3. And if we have greater than 5 teeth loss as a result of periodontal disease, it's stage 4. I also want to point out here as well that if you have a patient that you're seeing for the first time and they have 5 hopeless teeth, and you know that those teeth are still present in the mouth, but they're deemed hopeless and we're going to have to take them out, you actually include that in the staging. They actually may still be present, but they will be coming out. And so the workshop deems that as having 5 teeth lost, okay? Now, conversely, it's the same thing if you have a patient coming into your office and they have maybe 5 teeth that are missing, and you go and you probe them and they have clinical attachment loss of only 1 to 2 millimeters, okay? If that's the case and we don't know why the teeth have been lost, we might accidentally classify them as stage 1. So it's very important that when the teeth are lost, and we see patients with missing teeth and we're performing an assessment on them, we really need to ask them why they lost the teeth they've lost, because the stage 1 may actually be a stage 3 or stage 4. And the reason that's important is because periodontal disease is multifactorial. And if they lost teeth due to periodontal disease, they have an activated host response, which means the risk of them having further tooth loss actually is higher. So we don't want to underdiagnose, or we don't want to define our patients. Then we look at the complexity, and the stage 1 and 2 are mainly horizontal bone loss. And then we have stage 3 and stage 4. And the differences between stage 3 and stage 4 is we end up now also having vertical bone loss and furcations. But stage 3, the dentition is actually still intact. So they still have an intact dentition, although they have some tooth loss and maybe some ridge defects, still they're able to function. Stage 4 is when they have really drifting of teeth, malpositioned teeth, and they are at great risk of actually having complete dentition loss, okay? Looking at secondary occlusal trauma, bite collapse, drifting, flaring. Okay, and then when we look at this, we also add the extent. And the extent is whether they are localized, generalized, or they have a molar incisor pattern. We really don't want to we don't want to miss that. We find that that's actually a really good determining factor of whether it's chronic or aggressive, although we don't call it that. But a molar incisor pattern really will tell us a lot about the patient's periodontal destruction. Taking a look further, let's break this down just a little bit more, just to show you. Staging 1 just has 1 or 2 millimeters of clinical attachment loss, okay, and no more than 15% bone loss. And if you can see, sometimes it could be a little deceiving, and that's why I really recommend that you use periapicals, and that's why I recommend that you also use bite wings to define these stages. I find that with Panorexes, it is a little bit difficult to see the bone loss. Stage 2 is where we have about 3 to 4 millimeters of clinical attachment loss. And we start to see that the bone breakdown is between 15 to 33% of the bone loss along the root of the tooth. Stage 3 is where we end up having greater than 5 millimeters of clinical attachment loss. We end up getting furcation involvement. And although we can't define furcations radiographically, we can see interseptal bone loss that is consistent with furcations, but we'll also have the periodontal charting as well. And we have quite a bit of bone loss. We're starting to see some angular vertical bone loss here, and extends beyond 30% of the root of the tooth. And stage 4 is, again, where we have a collapse of the occlusion. And we really do have a great risk of actual true loss of the dentition. Okay. Now, can staging be modified? And that's really a good point. If a periodontitis patient is staged at a certain degree, even after treatment, their staging will always stay the same. Because even with periodontal treatment, such as open flap debridement, okay, periodontal surgery, they still have that clinical attachment loss, and they still have that bone loss. So staging never changes for a patient, except for one time. And that is when we actually perform regenerative procedures. Okay, if we perform a regenerative procedure on a patient and we can actually gain bone, by the way, this is my case. This is a case that's over 10 years old that I treated. Very close to losing this tooth, I performed a bone graft to correct that infrabony defect. And because now the clinical attachment level has changed due to the regenerative procedure, that is the one time that staging is allowed to be modified. And that's really the only time according to the World Workshop. Now let's take a look at grading. Grading will tell us the rate of progression, the response, and it even says it right up here, the rate of progression. Okay, this is where we are predicting the future. This is where we are defining future progression of periodontal disease, and this is where we define the treatment for the patient. The rate of progression, the response to standard therapy, and also the impact on systemic health. Periodontal disease can impact systemic health. It can increase the acute phase proteins in the liver and create systemic inflammation. We are still learning, and new evidence is emerging on that. So for the sake of us as clinicians, let's consider grading as looking at the rate of progression of periodontal disease and the response to therapy. Okay, so ideally, the way to determine grading would be if we were able to monitor a patient longitudinally over a course of several years. That's why it's so great to have patients and have clinical charting that will help us see the evolution of a patient's periodontal health. The primary criteria to determine the grading of a patient is direct evidence. So we have 3 grades: grade A, grade B, and grade C. Grade A means it's a slow rate of progression of periodontal disease. That's what we anticipate. Grade B is a moderate rate of periodontal disease, and grade C is a rapid rate of periodontal disease. And the workshop wants us to start off with determining that everybody is grade B, a moderate rate. And there's a reason for that. There are studies that show that 80% of the patients that develop periodontal disease will be at a moderate rate of progression, which means there will be periods of breakdown and repair of the periodontium. Maybe about 11% will have a slow rate of periodontal disease, and about less than 10%, about 8% will have a rapid rate of periodontal disease. So the workshop wants us, and talk about making it easy for us, we always start with patients having a grade B, and then we work our way to see whether it really is a grade A or a grade C. So if we do not have a patient is coming to me as a periodontist for the first time, which is very common for me. Although I would love to see direct evidence of progression, or perhaps a patient's coming to you and they haven't been seen by a dentist in 10 years. Well, if we don't have the ability to see how much bone loss or clinical attachment loss they've had over the period of 5 years, if we do, it's great. No loss over 5 years is a grade A, less than 2 millimeters over 5 years is a grade B, and greater or equal to 2 millimeters is a grade C. But what if we don't have that? What we do is a very simple calculation. Again, we take the worst tooth in the mouth. This is the beautiful thing. We don't have to look at everything as a whole. Periodontitis, the diagnosis, has been established. We're now defining it. And thank you, World Workshop. Thank God for you, and thank you, because we are just looking at the worst tooth. They're making it easy for us. And what we do is we take the tooth that has the most destruction, and we calculate how much bone loss, the percentage of bone loss divided by the age. And then we come with a numerical number. If that number is less than 0.25, it's a slow rate. If it's 0.25 to 1, it's a moderate rate. And if it's greater than 1, it's a rapid rate. So suppose we have, and actually I'll show you, if we have a patient that has 80% bone loss and they're 20, I mean, that's going to be greater than 1. We know that they have a rapid rate. What does that say to me? The rate of progression, they have an activated host response. They have a rapid progression. They definitely need to be under the care of a periodontist. And we may even have to do some serum testing just to actually determine the microbial profile as well, just to help us. I'm not going to be seeing that patient every 9 months. Okay, I may even see that patient every 2 months for cleanings. Okay. And also grade A will be heavy deposits of calculus biofilm with very low destruction. Grade B, where the level of biofilm actually is equal, makes sense for the level of destruction. And grade C is where we have very, very little biofilm, but a lot of destruction. And then what we do is then we determine the risk factors. So remembering what I said earlier on in the presentation, smoking and diabetes actually plays a role in further rapid destruction of periodontal disease. So if they don't smoke and they don't have diabetes, we can also classify them as a grade A. Grade B is if they smoke less than 10 cigarettes a day, or if their hemoglobin A1C is less than 7%. And grade C is if their hemoglobin A1C is greater than 7 and they smoke more than 10 cigarettes a day. And so what is the big deal about hemoglobin A1C? Well, a red blood cell contains hemoglobin molecules. And when we have sugar, and when we eat a high sugar diet, we end up having glycosylated hemoglobin. Okay, what ends up happening is the excess sugar in our diet, which is especially important for diabetics who can't process sugar, that excess sugar in the blood will actually bind to hemoglobin. And the problem is, and they irreversibly bind to hemoglobin and cannot be unbound. The lifespan of a red blood cell is about 120 days. And so these sugar molecules will attach to hemoglobin within a red blood cell for 120 days. And there are two general ways of determining the blood sugar level of a diabetic. One is the home daily tests, and one is a hemoglobin A1C test. And a hemoglobin A1C test is measuring the glycated or the sugared hemoglobin on a red blood cell. And in doing so, when you have patients who are monitoring their blood sugar at home, if they had a high sugar diet, they can always fast the next day or for a week, and then maybe they'll have another high sugar diet and then fast. So the thing is, there's a bit of cheating, and I say that reluctantly, but their hemoglobin or their regular daily blood sugar levels will fluctuate. And it can be modified depending on the diet. But a hemoglobin A1C test can never be modified, because once a high sugar diet is eaten and the sugar molecules actually bind to the hemoglobin, they're irreversible. And that way, that gives us a more accurate prediction of the stability and the blood sugar level in a patient. And hemoglobin or diabetes, let me just go back. In the hemoglobin A1C, we measure in a percentage. If a hemoglobin A1C level is less than 7%, they have good control. If a hemoglobin A1C level is about 7-ish, 7.4, 7.6, got to be careful, okay? It's getting a little high. We're talking about some systemic risk, cardiovascular health, but in terms of periodontal disease, periodontal destruction. And poor control is more than 8. And so when a patient has a diabetes, the first thing I will ask them is, what is your hemoglobin A1C level? And that should be taken about every 3-4 months. And it's very standard that a patient who has diabetes will have a hemoglobin A1C level checked about every 3 months. And patients love it when you ask them what their hemoglobin A1C level is, because they're now a person. They're not just a mouth, and you care about them, and you can have a conversation about what a hemoglobin A1C level means in terms of periodontal destruction. And back to what I was saying a little while ago, a hemoglobin A1C level, or a patient who has uncontrolled diabetes, will have rapid or a greater periodontal destruction. They will have a poor response to therapy and greater tooth loss. So always ask the hemoglobin A1C level. In terms of smoking, patients, smoking is dose dependent. It has been shown that there's a correlation between smoking and severity of periodontal disease, and the number really is 10 cigarettes per day. So I really do like to ask how long they've been smoking and how many cigarettes they smoke per day. And studies actually show that if you smoke 10 cigarettes a day for just only 2 years, you will start to show periodontal destruction. And there is a local and a systemic effect of smoking on periodontal health. First of all, it changes the microbial profile from an aerobic to an anaerobic. And also you will end up having an upregulated inflammatory response. And that's the reason why we consider smoking and diabetes as risk factors. So again, the consideration for staging and grading is we use the worst affected tooth. And my friends, we have to know too that we have to use clinical judgment. I know that sometimes we might teeter between maybe wanting to call it a stage 2 or stage 3 or a grade A or grade B. We also want to use clinical judgment, and we want to be able to clearly in our heads be able to explain that clinical judgment. And again, staging and grading do not help create a diagnosis. The diagnosis of periodontitis has already been made. We consider staging and grading as guiding stars to better define that patient, to create a personalized risk assessment and more defined personalized treatment for the patient. So let's take a look here. I'm going to give you guys a few examples here. So I have a 43-year-old female with a specific concern of bleeding in the upper left area. Missing teeth 1838, but these have not been extracted for periodontal concerns, periodontal reasons. Based on my clinical assessment, we have probing depth of 9 millimeters on the 2-6 distal. We have clinical attachment loss of 6 millimeters, and we have a class 2 furcation on the 2-6 distal, okay? So How do we define staging? Well, the clinical attachment loss is greater than 5 millimeters. I looked at that 2.6 distal, which is the worst tooth in the mouth. Let me just go back. Worst tooth in the mouth, 2.6 distal. I know that there's a clinical attachment loss of at least 5 millimeters. So I circle for this one a stage 3. Then I look at the bone levels, and I think that it extends to the middle third of the root and beyond. It's greater than 30% of bone loss on the root. There is no tooth loss related to periodontal disease. And I actually do have a class 2 frication on the 2.6 distal that I've observed. Also, it's just at the cusp of localized to generalized. And I don't want to underdiagnose my patient or underdefine my patient. I don't want to overdefine my patient. But generally speaking, we tend to err on the side of more than less in this case, or at least that's how I feel. So taking a look here, we have majority being stage 3 that I've circled. There's a bit of stage 1 here because there's no tooth loss, and I consider that to be generalized. But looking that we're really leaning more towards the stage 3, I consider this patient to be a stage 3. And I really recommend that you take these charts that were provided by the American Academy of Periodontology, and like I said, please email me. I'm happy to send them to you if you can't access them on their website. And you literally upload these in the patient's chart, or you have them chair side, although I know nowadays chair side's a little bit of a funny one. And you circle this, okay, just the way I am here. You don't have to do this in your head. You start circling this. Now let's go to grading. Well, I'm seeing this patient for the first time, so unfortunately I don't have direct evidence of progression. So what I do is I do a calculation. I suspect that she has about 40% bone loss on the 2.6, and she's 43 years old. 40% divided by 43 is 0.93, which takes me into this category here. Okay, I personally think that the amount of bacteria is reflected with the amount of destruction. She doesn't smoke. She doesn't have diabetes. However, because she is a grade 3 for these two areas here, I'm going to consider her as being grade B. So the ultimate definition is periodontitis, stage 3, grade B, generalized. It's as simple as that. Okay, let's go to the next one. Okay. I love this patient. I do. 31-year-old female, 31. Okay. New to the practice. I was told I need a gum exam. Did not see a dentist. She told me she knew her gums didn't feel right. She was a student. She was building her career. Just couldn't quite get around to seeing the dentist. She now has insurance. She now feels a bit stable in her job. She knew she wanted to see a periodontist. Something doesn't feel right. Okay. We review the medical history as well, non-contributory, non-smoker, non-diabetic. We define her based on her level of clinical attachment loss. We have at least clinical attachment loss on 2 non-adjacent teeth. I define her as periodontitis. Now let's stage and grade her. Well, when I take a look, and by the way, I'm sorry guys, with COVID, I didn't have access to all the x-rays, but I do have a full set of x-rays. But I wanted to isolate here too, that I have the greatest destruction, again, on 2.6 on the mesial. I have 8 millimeters of clinical attachment loss, class 2 frication. That's the worst one. So let's go to staging. Well, taking a look, again, I know that I have clinical attachment loss of greater than 5 millimeters, so I'll circle that one. Looking at the radiographic bone levels, it's extending to the middle third of the root and beyond. She doesn't have tooth loss related to periodontal disease, so I'm going to say no tooth loss. She has vertical bone loss, and she has frication involvement. Her dentition is still intact, which is why I'm not considering it a stage 4. She doesn't have any collapse of her dentition. So and she is generalized, okay? More than 30% of the teeth are involved. So I look at this and I'm going to classify her as a stage 3. Easy as that. Now I go to the grading. Well, when I take a look at that too, there's 60% bone loss on the 2-6, and she's 31 years old. I do not have any direct evidence of progression. Okay, although I have to say I would love to have seen that on this patient. So 1.9 is greater than 1, so I'm going to stage her as a grade C rapid. Destruction, I will say, does measure. She had quite a bit of biofilm, and I do think it's consistent with the level of destruction. Non-smoker, non-diabetic. But, so look, we're all over the map. We have a bit of grade C, we have a bit of grade B, we have a bit of grade A, but we always err on the side of the most advanced rating. In this case, it's grade C. So how am I going to classify her? Periodontitis, that's generalized. Staging is 3 with a grade C. Let's go to the third one. 60-year-old female, history of periodontal disease. She knows she has periodontal disease. No surgery. She's been maintained. She moved from a different province. At this point, I was not able to get any other measurements, although from the previous periodontist, although I would like to see those. She's a type 1 diabetic with a hemoglobin A1C of 7.9. Not very stable. She's aware she's not stable. Smoker, 1 pack a day for the last 30 years. And if we take a look, we do have some bite collapse here. So let's go to the staging. Looking here, I know we have clinical attachment loss of greater than 5 millimeters. We definitely have bone loss that extends beyond the middle third of the root. She actually has lost teeth from periodontal disease of more than 5. And she has a bite collapse. She has teeth that are drifting, malpositioned, flaring. So we do have the concern of the need for rehabilitation. And this is a generalized distribution. The grading, well, when I take a look at the worst tooth, I see that there's 80% bone loss on the worst tooth. She's 60 years old. 80 divided by 60 is 1.3. So 1.3 is greater than 1, so I consider her as a rapid rate. I still will put her into a grade B, moderate right now, and she smokes greater than 10 cigarettes a day, and her hemoglobin A1C is greater than 7, okay? I consider her as having periodontitis, stage 4, grade C, that's generalized, and I have modifying factors of smoking and diabetes, okay? Very straightforward classification when you're able to break it down like that. So what does that all mean? How do we treat these patients? Stage 1, that's otherwise grade A or grade B, I consider standard periodontal therapy. There's already some clinical attachment loss. I personally would put them into a recall program that is modified. I don't think I'd keep them on every 6 months or every 9 months. I'd probably stick to every 3 months or every 4 months. And I may consider some pharmacological agents, maybe some Arestin, maybe some Atrodox in some areas, but I would definitely modify that recall program. Stage 2, that's otherwise grade A or grade B. Again, I would consider standard periodontal therapy, meaning for me, that means scaling and root planing. But I do want to assess the response to the scaling and root planing, which means I will do a standard scaling and root planing. I may even do that with local anesthetic. And then I will bring that patient back 6 weeks later to assess their response to that therapy. And I will also take a look at their staging and grading. As I said, staging really doesn't change unless we do regenerative therapy. We never stage down. This is important. We never stage down, but we can stage up. So when I say it doesn't change, we can never grade stage down, but we can always stage up, okay? Except for regenerative therapy. That's the only time we can stage down. I want the reassessment following their initial response to therapy. And again, I may consider some local delivery antibiotics for the patient. Stage 3, that may be grade B or C. This is where we really need a multidisciplinary approach. This is where an experience level, where the experience of a periodontist will come in play. You may even need this here for the stage 2, especially if they don't respond to the initial phase of therapy, which means you did scaling and root planing on a patient. You brought them in 6 weeks later, but they didn't respond to the therapy that well. That's when you get a periodontist involved. Stage 3 will be multidisciplinary. What that means is we are going to get involved. It's going to be a team approach. I'm going to help you guys, or a periodontist in your area is going to help you with this patient. It may need oral rehabilitation. We may need to remove some teeth. I may even consider some host modulating things such as Periostat, which is 20 milligrams BID. And stage 4, that's B or C, again, that is complex. That's when I really advise some more advanced experienced care with a periodontist, general dentist, prosthodontist maybe, and we want to look at oral rehabilitation for the patient. So the World Workshop classifies and defines a patient as such. A periodontitis patient is a periodontitis patient for life. If a patient has a low threshold to biofilm, and if a patient has an activated host response to periodontal disease, they will always have a susceptibility to periodontal disease. Gingivitis can be reversed to health, but a periodontal patient, even after surgery, will always be a high risk of further periodontal breakdown. And that is why oftentimes when I see a patient and I've done periodontal surgery on them, I will actually alternate recall systems between my office and my referring practice. Reason being is because they need some guidance so that we can have a dual check and assessment of the patient on a regular basis. So the 3-month alternating recall between a periodontal practice and a general practice is such to make sure that if we find as periodontists any subtle differences or changes in the periodontal health of the patient, we can actually alternate or modify their treatment in such a way that we can limit or arrest any further periodontal destruction for the patient. So with that said, if you guys have, I'm not finished yet, okay? I just want to talk just a little bit more about periodontal health. I just want to give you guys just a little bit of a break. I only have a few more minutes to go. But if you guys have any questions about this, please reach out to me. If you guys want access to the staging and grading, email me. You can reach me through my Instagram. I have 2 pages, Dr. Tina Kokosis and Global Dental Academy. And you can also email me at gda_education@yahoo.com. I'm going to change trajectory just a little bit here, and I want to talk about peri-implant diseases and conditions. I'm only going to touch upon this peri-implant health, mainly because I think that it really deserves its own lecture. And I'm happy to prepare a lecture. In fact, I'm in the process of actually creating and modifying a peri-implantitis lecture that I do have. I just really think that this really deserves to be highlighted in its own unique discussion. But let's talk about peri-implantitis, or even just define peri-implant health. There are some distinct differences between the periodontium around a natural tooth and the periodontium around a tooth surrounding an implant. When we look at a tooth over here, we have dental gingival fibers. So we have dental gingival fibers, which are fibers that attach from the tooth to the gingiva within a natural dentition. That actually does not exist around an implant. We do not have gingival fibers, okay, that actually attach from the gingiva into inserting onto the implant. We might have a long junctional epithelium, but a junctional epithelium are not dental gingival fibers. It's just an epithelial attachment to otherwise the tooth or the implant. Those distinct differences are important because when you actually try to probe an implant here, what you will find is the probe will have less resistance, and it will also have a deeper probing depth. And we need to define whether that's okay, whether a deeper probing depth is acceptable or not. Another concern, or not concern, but observation, is implants are inserted at different levels. So we may have an implant that's submerged more and may have a deeper pocket. We might have one that's submerged not as much, but still deep. And then we might have one that's submerged a little more supercrustally. So unlike a natural dentition, a probing depth around an implant that's a little deeper is not always necessarily a signal of periodontal destruction. So the World Workshop defined peri-implant conditions as four main subheadings: peri-implant health, peri-implant mucositis, peri-implantitis, or soft and hard tissue deficiencies. I'm going to touch upon peri-implant health, peri-implant mucositis, and peri-implantitis right now. So I should have created a poll, but I did not. But to probe or not to probe, that is the question. How many times have we sat around debating whether we should probe an implant or not probe an implant? Okay, I just want you guys to think about.
Sorry to interrupt. Do you want me to create a poll for you real quick?
Yeah, let's do a probe for about 15 seconds. How many think we should probe and how many think we shouldn't probe an implant?
Okay, so the question should be, how do you think we should probe the implant, yes or no, right?
Yes, please. Perfect.
And I apologize in advance if there's any type of issues with the spelling. So the question asks, do you think we should probe an implant, yes or no? Are we okay with that?
Perfect. And I can't see the poll, so you let me know.
Absolutely.
Thank you.
Alrighty, so I'm going to go ahead and launch the poll, everyone. So you just have to click yes or no. And once again, the question is, do you think we should probe an implant, yes or no? We're going to give it about another 25 more seconds. We currently have 160 people who have voted so far. We're going up to 170. All right, we'll give 10 more seconds here. 5, 4, 3, 2, and we'll go ahead and end the poll, and we're going to show the results, and we'll share it with everybody. So the results show that 82%, or 151 of our participants, have said that yes, they should be probing an implant.
Yay, I love it. That's great. And I have to tell you, that is one of the greatest debates in our dental profession when it comes to implants. Because I'm going to be honest with you, I didn't know the answer. I truly did not know the answer. I liked probing. Then I was criticized for probing. Then maybe I wasn't criticized for probing. And the reality is we didn't quite really know. So there is a resounding, you know what, let me just close that. I actually see the poll. Yeah, so the answer is yes, we should probe. We do want to probe with a plastic probe, not a metal probe, to not create any damage to the structures of the implant. The question though here too is, what else do we need in terms of probing? When we determine the health of an implant, we should include probing, and also we should include visual inspection and digital palpation of the implant. So when to probe an implant? Following the delivery of the crown, ideally at some point, you should probe the implant to consider and establish a baseline probing depth. Now, so I'm lecturing based on the workshop. okay, not based on my personal opinion. I didn't quite see when, after the delivery of a prosthesis, the workshop recommended probing. I would probably say at least maybe 6 to 8 weeks after that to develop the junctional epithelium attachment on the crown. But I really do think that a baseline probing should be established, okay? We also would like to have a radiograph at the time of the prosthetic delivery. And after a certain loading period, which wasn't well defined, but I like a loading period of 3 months, 6 months, and then a year, we do recommend radiographs and probing depths, okay? And if a patient is new to your office, what we recommend is establish baseline probing depths. It would be nice if a patient's new to your office to see if you can reach out to the dentist or specialist to place the implant so you can get some baseline information at the time of the prosthesis delivery. Peri-implant health is evaluated by visual inspection. First, you want to see if the tissue is pink. You want to also do some digital palpation, check for firmness, and you want to make sure that it's not swollen. You don't want to see any erythema around it, any bulbous tissue, any swelling. When you do probe, sometimes you might get pinpoint. You might get pinpoint probing, bleeding on probing. But if you see here, the workshop defines it as lack of profuse bleeding on probing. Because again, just the same as gingival health, the reality is it's unrealistic to actually expect that we're gonna have no bleeding on probing. What we want though is we might get little pinpoint bleeding on probing, but we don't want that profuse bleeding on probing. We also want to make sure we don't have we want an absence of bone loss with time. We do know that there might be some bone remodeling, but the probing depth should have less than 5 millimeters, or the probing depth should be less than 5 millimeters ideally. Although, as I said, sometimes it's hard to define a true healthy probing depth measurement around an implant. Ideally, we want it to be 5 millimeters or less, and especially because a pocket that's beyond 5 millimeters really is anaerobic in nature and really will have a developmental of more anaerobic bacteria. And we want to make sure that there's no changes in probing depths over time. Peri-implant mucositis, I would compare that to gingivitis in a healthy dentition. Peri-implant mucositis is essentially gingivitis around an implant. Visual inspection, we could have signs of inflammation, erythema, swelling, redness. Patients will complain of soreness. There could be bleeding on probing, and we might have some exudate. We might have some suppuration with the bleeding on the probing. As you can see here, we've got that bulbous, glossy, erythematous nature bleeding on probing. But we will have absence of bone loss after the initial remodeling. And the nice thing is we might have an increase in probing depth. And a lot of that also comes from the swelling of the tissue. But we really, with peri-implant mucositis, just like gingivitis around a tooth, we will not have bone loss around this implant. Peri-implantitis is periodontal disease around an implant. And that is defined as signs of inflammation, redness, swelling, softness of the tissue, soreness. Patients will complain of soreness. There could be and probably is bleeding on probing and some exudate. And we will see in this case progressive bone loss. Okay, now patients who have a history of severe periodontal disease that get implants actually have a higher risk of peri-implantitis. And that is why it is so crucial before we put an implant into an edentulous site, an edentulous patient, in a patient who has multiple teeth missing. We need to start asking patients, and I bet you guys already do this. We need to ask our patients why they lost those teeth in the first place, okay? And I've provided for you guys a little checklist, and you can modify this. You can take a screenshot. I'm happy to provide the PDF file for you guys. But you can actually take this or create your own chart and actually do a chair-side checklist. So I had the sweetest dentist who connected with me on Instagram. I won't say his name, but he was so sweet. He was so excited for attending this course, and he actually created a checklist that's a chairside checklist similar to this, but his is fancier, and I like his a lot more. But chairside, you can actually take a look here and do a visual inspection, digital inspection. You can actually just check this off. Peri-implant health, the probing will be variable, okay? Peri-implant mucositis will not have bone loss, and it really shouldn't have recession, and peri-implantitis will likely have all of the above. Like I said, feel free to screenshot this, and also feel free, I'm more than happy to just send this over to you. And guys, that concludes our new classification, which is not so new anymore, of periodontal disease and peri-implant conditions. The verification code to receive your CE credits is 0527. If you are an AGD member, also please provide, and you can do it privately, send me, otherwise through my Instagram pages or through my email, send me your AGD membership, and I'd be more than happy to provide register this course for you so you can get your AGD credits as well. And with that, I thank you very, very much. Dentistry Academy, what can I say? I love you guys. Thank you very much for really an incredible journey during this time of a lot of uncertainty. I also want to thank the surgical room just for their support over this time. Thank you very much, everybody, and I hope you have a great evening. If you guys have any questions, please, I'm happy to stay on as long as we need to.
So Tina, we have a couple of questions here. The first one is from Melvin. Melvin asks, when you say grading indicates the responsiveness to the standard therapy, does that mean that grading is determined after periodontal treatment?
It could be determined. What that does is it will help us determine whether they're going to respond well or not. Grading can be done before, and it can be done after therapy. So you can actually, when we do our therapy for our patients, we will actually restage them and regrade them.
Awesome. Thank you so much for that. The next question is from Mohammed. He asks, for grading, if your bone loss / primary criteria is grade B, but patient smokes more than 10 cigarettes a day, is this patient now grade B or grade C? I.e., does the primary criteria mean more versus the grade modifiers?
You know, that's such a great question. And that's where sometimes it can get a little confusing. And that's where your personal judgment actually comes into play. I personally would grade it as grade C.
Thank you. The next question comes from Todd. Todd asks, when scaling, if there are pockets deeper than 4 millimeters, which we know we cannot fully clean, should we clean these sites still knowing that we are likely trapping plaque / calculus, which could lead to abscesses?
Absolutely. When I see pockets that are about 4 millimeters, I will scale them. A lot of times it could also be a result of inflammation. So the whole goal is to scale that 4 millimeter patient. And by the way, you could probably scale up to 5 millimeters, maybe not so well. I would scale them, I would bring them back, I would reassess them. A lot of times you'll get soft tissue response. That 4 millimeter may even start to become a 3 millimeter. You may even see visual signs of that calculus and go in and scale. And if you find, and then you monitor them. I would not do periodontal surgery on a 4 millimeter pocket. In fact, studies show I could create greater attachment loss if you actually do periodontal surgery at a 4 millimeter pocket. So I would monitor them every 3 months. And if I find they're getting progressive, okay, to a 6 millimeter pocket, I would do open flap debridement on them. But yes, 4 millimeters, absolutely scale. Awesome. Local anesthetic, by the way, might be helpful maybe for some patients.
Awesome. Thank you so much for that. I believe that is all the questions that we have for today. Just a couple of quick reminders. So tomorrow at 6 p.m., the same time as tonight, we have Dr. Naheed Mohammed, who will be lecturing on minimally invasive soft tissue grafting techniques for teeth and implants. So make sure that you all tune in tomorrow. And also tomorrow morning, starting at 11 a.m., we have Dr. Jake Carrier, who will be talking to us about the new dentist journey to practice ownership, followed by Dr. Michael Rondinelli, who will be talking about leadership, growth, and financial success. Make sure that you tune in. dtacademy.ca. And for tomorrow morning sessions, as always, the password is track20. That's all caps. And for the evening session, there will be no password to that one. So make sure that you sign up early. And then we will be concluding the Dental Fast Track series with the one and only Dr. Mian Kwek, who will be talking about rethinking success and now mindset for dentistry. And that will be on Friday at 12 p.m. Make sure you tune in. Thank you so much, Tina. That was an absolutely lovely lecture. And once again, you make it seem so easy, no matter how complicated it is.
Well, thank you so much. You know, I hope I was able to provide some, I guess, level of ease in a schedule that kind of feel very daunting. I'm just wondering, should we keep this open just for a few more minutes just to make sure that everybody's actually gotten their emails up? Is that something that...
Yeah, so yeah, what we can do is make sure that you type in the AGD verification code and your email address if you haven't done so already. Once again, the code is 0527, and we'll need your full name and your email address. And if you haven't done so, please, as a reminder, to do so, just for CE verification purposes. All right, and we'll leave it on for about another minute or so, just to make sure if anybody hasn't done so yet to type their information in. Everybody says thank you, incredible presentation, great presentation from Susan. Megan says incredible. Thanks, Dr. Tina, you're an inspiration. Raya says thank you, Dr. Tina. Michelle says incredible work as always.
Well, you know what? I feed off of good people, right?
Awesome. This is really good, and thank you for that. Honestly, you made it seem so easy. All righty, so
we'll be practicing it together, right?
Yeah, absolutely. We'll give it a couple more seconds. And I see Lisa here saying thank you so much for a great one. Thank you, Dr. Kokosis from Marcella. Jenny says thank you.
Yeah, and if you guys want slides, I see a few people asking me for the slides. Do me a favor, just email me at gda_education@yahoo.com. And I'm more than happy to provide these slides. By the way, we can upload them on Dentistry Academy as well. We're doing that, right?
You got it. This presentation will be uploaded on our Dentistry Academy YouTube page, so make sure you subscribe. And it should be uploaded, whether it's probably tomorrow or Friday at the latest.
Great.
Awesome. Perfect. I think that is it. I think we're good there. Firas says, thanks, Tina. Great presentation.
Wow. And for those of you, for those who maybe just missed it and we're closing up, just like I said, message me on Instagram or my Yahoo account.
You got it. Yeah, there's still a couple more coming in from Kateri, a couple of other individuals just typing in their information. So, and if we missed it, can you just say the email address one more time, Dr. Tina, before we go ahead and close off the room?
Absolutely. So it's gda_education@yahoo.com.
Awesome. Thank you so much.
And you can also,
Go ahead.
Never mind.
Awesome.
I was going to say they can also email you, but then you know what? It's probably better that it's one source. I'd say about that. Yeah.
Awesome. Perfect. Well, thank you guys so much for attending today's or this evening session. Have a great day. Stay safe, and we look forward to seeing you all tomorrow. Thank you so much, Tina.
Thank you, guys.